I'm excited to share with you some interesting things that I think and hope will be informative for you. A little bit about the biology, a little bit about mechanism of action, and then the targets in our panel, and then some things that the research and development and clinical studies have demonstrated how these are connected, and some of the interesting takeaways that may help you in your practice, because our goal here and the reason we started the company was to help support and provide information so that you can diagnose and better treat your patients with these chronic illnesses. So with that, let me share with you what we're going to cover today. First, we'll talk about the biological basis of how infections can trigger autoimmune dysfunction, and that results in these various types of neurologic, psychiatric, and behavioral disorders. And then the question as to why certain infections tend to be present in these patients with these autoimmune neuropsychiatric disorders, such as PANDAS and PANS, neurologic Lyme, and even long COVID. And there's a commonality that has to do with why these certain infections tend to be reoccurring. And then how the biological targets, and specifically these 5 targets in the Cunningham panel, and I'll probably refer it to also an autoimmune encephalitis panel, that can diagnose and direct therapy to your patients with these immune-mediated neuropsychiatric disorders that are a result of an infection. And then I'll share with you some of the common symptoms that we find in patients who are positive in testing, and that they respond then to these types of treatments that I'll just describe in general therapeutic categories that have shown clinical effectiveness in treating these autoimmune encephalopathies and what we'll call basal ganglia encephalitis also. Excuse me. So with that, let me share you a little bit of the dilemma here in the diagnosis of various neurologic, psychiatric, and behavioral disorders. Currently, the vast majority of them are all classified by symptoms. So clinical presentation is how these disorders are classified. And I put up a handful of them here. And as you can see, in the case, let's say Tourette syndrome, a patient that may have motor or vocal tics for more than 12 months, that does meet the diagnosis for a Tourette syndrome. Now, there's more to it, and there's other rule-out types of identification, but because these are clinically based symptom diagnosis, they are based on these symptomatic signs and symptoms, but not biology, which does kind of pose a problem because many of these different types of disorders, including, as you see here, seizure disorders and epilepsy, it's known that at least maybe somewhere between 30 to 50% of epilepsy has an autoimmune basis and don't respond to standard epileptic medications, as is the case with many of these other disorders because they're diagnosed by symptoms rather than biology. So that's part of the challenge that you face. The other is that the standard of care for neuropsychiatric disorders focuses on treating the symptoms and in some cases coping. So the advent of psychotropic drugs has been very impactful in treating many of these disorders because previously, and we won't go into too much of the history, but there were things like even boring holes in your head, lobotomies, straitjackets, fever-inducing, a whole host of methods to try to deal with psychiatric disorders. And with the advent in the 50s of psychiatric drugs, there's been quite a bit of a growing use of them. If those don't work, or if they're in conjunction with things that can work, psychotherapy, and then ultimately, if none of those work, institutionalization. The challenge is that often what accompanies that is increasing suicide rates, or black box warnings from the FDA indicate the risk of suicidal ideation, and it is something to be aware of. So really this comes back to the question of, can infections really trigger neuropsychiatric disorders? Well, there's a growing evidence, and I'll just share with some that kind of highlights this, and this is in JAMA Psychiatry, published in 2019. It was a study of over 1 million individuals that were followed from birth to age 18. And they found an interesting observation, is that if a person was hospitalized for a severe infection, that the risk of developing a mental disorder increased by more than 80% for the diagnosis of schizophrenia, autism, OCD, ADD, ADHD, personality disorders, and many other types of disorders. So the authors and the editors posed the question, how could exposure to infections affect the brain mechanistically to give rise to mental disorders? They said that circulating autoantibodies that enter the brain via compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation, and this mechanism has been proposed in PANDAS and other mental disorders. So you may or may not have heard, but hopefully you have, about PANDAS and PANS. And these are representative models of acute onset of these neuropsychiatric disorders due to a certain infection. So Brain on Fire, which some of you may have seen, Hollywood has produced a movie. Susanna Callahan has written a book, which is a story about her life, which started with this infection and then sudden onset of symptoms that resulted in the potential diagnosis of schizophrenia and bipolar. She was hospitalized, symptoms of psychosis, paranoia, hallucinations, and an astute physician identified that she was suffering from an infection-triggered autoimmune neuropsychiatric disorder. In this case, it's called NMDA, or receptor encephalitis. So one thing, brain reactive antibodies have been known in medicine for a long time. In fact, there's a very long and growing list of them. Most of the early ones have been associated with paraneoplastic diseases. And so the mechanism is very similar in that these antibodies, which cross the blood-brain barrier, bind to some type of receptor in the brain and interfere with the normal signaling that goes on in the person's either CNS, the brain, or other parts of the nervous system. We also see that over time, these are neuronal antibodies or neural antibodies, but those are the antibodies that are targeting different types of neural receptors, and they're increasing in number as far as they're being discovered and understood and also then published. So what we find is that the question of how does this occur biologically is that we all get exposed to microbial, viral, fungal infections. We see that, of course, obviously with COVID. But our body responds through our adaptive immune system by producing antibodies that recognize these infectious organisms. That's just the way that our immune system is responding. Whereas in some individuals, the antibodies that they actually make against these targets are the targets in those infections that are either identical or very closely related to targets in the body. In these cases, neurologic receptors, we call that molecular mimicry, meaning that at some point in the protein alphabet, there's a string of letter sequences that are either identical or very similar to each other. And when antibodies are directed against them, then they produce antibodies that cross-react parts of our body. In this case, as mentioned in the journal article, that they cross the blood-brain barrier and interfere with normal brain function in the brain. We kind of call that as an analogy to the friendly fire in the wartime, where you have difficulty distinguishing the good troops from the bad troops. This results in the neuropsychiatric symptoms and many heterogeneous symptoms that we described, including movement disorders and seizure disorders and even epileptic types of symptoms. Patients tend to be placed on various types of symptom response or treatment responses to the symptoms. But in these cases, patients actually do not improve, and often in some cases, they do get worse. COVID has shown us a very similar situation where the spike proteins of the SARS-CoV-2 virus has some similarity to targets in the brain. As patients actually generate antibodies to common epitopes that are similar, they can result in other types of these neuropsychiatric symptoms. They also have commonality to some targets in the heart, which we see myocarditis, cardiovascular conditions, chronic fatigue-like types of symptoms where there's brain fog, and we'll talk a little bit about that and how that the targets in the panel actually can help with identifying that. So here's a study that was done in children with OCD and tics that were associated with streptococcal infection. What they found was that certain parts of the brain actually were inflamed. Those were the caudate, the putamen, the globus pallidus, all of which are portions or parts of the basal ganglia, whereas not the thalamus, which is not part of the basal ganglia. And the important part of that is that the basal ganglia is responsible for a number of functions: voluntary motor control, procedural learning, cognitive functions, emotional functions, and even eye movement. And so when you interrupt or interfere with the normal functioning of the basal ganglia, you can expect to see different types of repercussions from interfering with normal biological function of the basal ganglia. What that, in kind of a summary fashion, is showing us is that there is an interconnection between infections, the immune system, and the brain functions. And these can be from bacteria, which we'll talk a little bit about, strep, some of the viruses, as we know, from SARS-CoV-2 or COVID, and the immune system response. In this case, autoimmune antibodies, inflammation, microglial activation, cytokines, mast cell activation, and then the interference in the brain functions, all which is in a context of a genetic predisposition to an immune system dysfunction. And the reason we do see that is because in these patients, you will typically find in the family history that there is some history of some type of immune system dysfunction, whether it be something on the order of even asthma, lupus, MS, Crohn's. You can see that there is some immune system dysfunction. And then in these cases, what can happen is the unlucky draw of the target in these cases are the brain proteins. So I want to briefly talk for a moment about nomenclature, because it can be confusing. If you've heard about PANDAS, which stands for Pediatric Autoimmune Neuropsychiatric Disorder associated with a streptococcal infection, this is referring to sudden onset of various types of neuropsychiatric disorders after a streptococcal infection in children. It has been known also that other microbes will trigger this, and that includes Lyme, Mycoplasma, Babesia, Bartonella, and other viruses. And then also it's believed that other types of environmental and biological factors can contribute or trigger this also. And so that gives us either infectious triggers or non-infectious triggers. And this is the reason PANS was coined. PANS represents pediatric acute onset neuropsychiatric syndrome, because it does include then not just strep, but other organisms, as well as environmental and other biological factors. Now, this still limits to children, whereas other terms have been coined, like ANDL, which has been referred to autoimmune neuropsychiatric disorder associated with Lyme, or in some cases, it's referred to adult neuropsychiatric disorder associated with Lyme. And then there are other terms which we prefer to use and see, irrespective of the age of the patient and the triggering organism, is basal ganglia encephalitis, or autoimmune encephalopathy, or autoimmune encephalitis secondary to infection. You will see that those terms will start to be more common because an adult can't have PANDAS by definition, nor can adult have PANS. And if you don't have strep, you can't have PANDAS because the S stands for streptococcal infection. So this is part of the nomenclature difficulty, which is important for categorization and study, but for diagnosis, it becomes a little more challenging. So by definition, encephalitis is just inflammation of the brain. Cephalopathy is any disorder or disease that is of the brain. And so these terms you will see and begin to see probably more common usage, which will also take away a little bit of the controversy, at least in some cases. You've got to show what the organism is, or you, in this case, you don't have to. So history itself is important. It helps us understand medical models. This infection-triggered autoimmune neuropsychiatric disorders are not new. In fact, they're very old, back to the 1800s and even the 1600s with Thomas Sydenham. There was described these by Sir William Ulzer, these bizarre and percipitive behaviors in children. He called them chorea minor, and also the symptoms of Sydenham chorea. The causative agent is group A streptococci. Antibodies made against certain portions of that, which we'll talk about in a second, are common to portions of the brain, particularly the basal ganglia, but also the manifestation of acute rheumatic fever is another target of that, and the same organism will trigger that. Of course, the treatment is antibiotics. And Sydenham chorea, which is rare to see in the United States, but it is still more prevalent in developing countries. It also used to be known as St. Vitus's dance. Patients will have lost abnormal movement or have abnormal movement. They lost motor control, especially the fine motor control, and then emotional symptoms that come with it. And again, remember the functions of the basal ganglia. We'll talk about that a little bit more in a bit. So I mentioned molecular mimicry, and this is the biology behind these infection-triggered neuropsychiatric disorders. So group A streptococci have M proteins and group A carbohydrates. In these cases, these M proteins have some common peptide sequences to various parts of the body. Normally, the immune system will tell the body, "This is me. Don't make an antibody against it." But in a dysfunctional immune system situation, what we will see is patients will have, excuse me, I think there's an auto move on this thing. I'm going to have to override it. Targets against, in this case, for rheumatic fever against the heart valve, basal ganglia for Sydenham chorea, but you'll also see joint and arthralgia and pain in patients with these conditions, and even kidney dysfunctions. And again, very similar mechanism from this, but these symptoms would not be unusual to see in patients who have these particular diagnoses. So what are those infections? I mentioned some repeating common infections that tend to occur because of these common sequence and epitopes. Group A streptococci is one. You see that. That's the reason PANDAS was coined. Influenza A is another one. You do see some situations in influenza A that do elicit other types of autoimmune conditions like narcolepsy. And so there was a high degree of association seeing in narcolepsy with patients who had influenza, and in some cases there was a particular vaccine that was processed in a certain way that elicited a very high, unusual number of narcolepsy patients. And the narcolepsy is an immune response to specific targets and proteins that are involved with sleep. Chickenpox, mycoplasma, Lyme, and we won't go into too much of that, but Lyme has some common epitopes with streptococcal M protein, Babesia, Bartonella, Coxsackie virus, and others. So these tend to be the ones that are frequently associated with patients with these infection-triggered autoimmune conditions. What you will find, and I'll show in a study in a second, is that these patients will have even other infections because with a compromised immune system, so to speak, other opportunistic infections will be seen. So it wouldn't be unusual to find one or more of these and some others that aren't, maybe have common epitopes to this in the same way these do. There is a financial impact and burden of care on these families, and this is something that we're preparing to work on as a manuscript and publish eventually, is that the burden of care on these families, and you who take care of these children, adults, families, recognize this. This was an add-in question that many patients have placed in here. I'm not sure why. I'm going to have to work on that. I'm getting some auto movement here. We've tested over 15,000 patient specimens in our clinical lab for these autoimmune neuropsychiatric disorders. What we find is that patients have visited between 5 to 15 doctors before they receive a proper diagnosis. And then the length of time from the symptom onset to diagnosis is about 3 to 5 years. Then approximately 3 to 18 additional months before they receive effective treatment. So for you who are taking care of patients with these, let's say, chronic neurologic psychiatric behavioral disorders that are maybe unresponsive to standard therapy, they will probably have seen multiple specialists and have been looking for help for a long period of time. So this kind of represents the challenge you face and patients see with autoimmune neuropsychiatric disorders, secondary to infection, and this says, never ever think outside the box. Well, as I mentioned, history does show us that this is the case, and these medical models are a good indicator of what we can help to understand so that we can develop better diagnoses and better treatments for these patients. So I'm going to move to some commonalities in the patients that we find. What are their symptoms, and what symptoms tend to be associated with positive anti-neuronal antibody testing in our panel? There are many, and I'll tie this into the basal ganglia in just a minute, but they do include the PANDAS and PANS symptom list, but also many others. So we see often there's a sudden or rapid onset of neuropsychiatric symptoms. That seems to be present, but also there are gradual onset in adults that we have also seen. And there's sudden or rapid onset of obsessive compulsive disorder. Restrictive eating disorder, in these cases, they're not the identity associated disorder, but rather an obsessive compulsive disorder, in that there's a fear of food contamination or a fear of choking, something that is more OCD related versus an image issue. Motor or vocal tics, or the little piano playing choreiform movements that are uncontrolled or unable to stop. Anxiety and rage, separation anxiety, emotional ability, depression, developmental behavior regression, mydriasis, or dilated pupils. It tends to be associated with what I'll share with the CaMKII results. And then there's this relapsing remitting course of this OCD. One of the clinicians that we work with has told us that every one of our patients that have these conditions, if you ask them, they will admit a suicidal ideation. This is an important thing also to recognize, because again, remember, you're dealing with something that's interrupting normal emotional control and behavior. I highlighted this one, treatment resistant to standard neuropsychiatric drugs. Typically, many of these patients have gone through multiple treatment regimens and haven't improved. And what you'll find is there is generally some unresponsiveness to standard treatment for, in the case of, let's say, epilepsy, non-responsive to epileptic medications, which may be an indicator that you should consider whether this is autoimmune. In the case of neuropsychiatric conditions and OCD, non-responsiveness to these. PANDAS and PANS diagnosis, symptoms, family history of autoimmune disorders, frequency of infections, and many of these actually are subclinical, and we'll talk a little bit more about those in a second, and post-treatment Lyme disease, or sometimes called neurologic Lyme. So going back to the basal ganglia functions, and I've tied this to the PANS criteria, which is another medical model, is that what we can see is that, let me go back here, fighting against these slides here. Anxiety, emotional ability, depression, irritability, aggression are emotional functions. You can see that. And then also the connection, apologize for that, behavior, developmental regression, deterioration of school performance can be tied to both cognitive functions and procedural learning. Sensory or motor abnormalities, and also somatic signs and symptoms, sleep disturbances, symptoms that could not be explained by neurologic or other medical disorders. And these correlate to the normal biological functions of the basal ganglia, hence the basal ganglia encephalitis term, but also there's evidence and data that has been published to show these antibodies that are produced bind to the basal ganglia and stain there and not other parts of the brain. So I'm going to shift attention for a second. What are the biological targets in the autoimmune encephalopathy or basal ganglia encephalitis panel that we call Cunningham Panel? There are actually 5 different targets, and there are 4 that are direct binding to them, and a 5th one that is actually a stimulatory activity based on an antibody that stimulates a particular enzyme. I'll talk about that in a minute. So these antibodies, if you recall, as what was described in the publication, can cross the blood-brain barrier, interfere with the pre or the postsynaptic neurons in the brain, and bind to, let's say, lysoganglioside, the dopamine D1 or D2 receptor, or stimulate the CaMKII, which I'll talk about in a second, which is responsible for upregulating the synthesis of dopamine, epinephrine, and norepinephrine. So you really don't want some artificial interference or stimulatory activity of motor neurons or neurologic neurotransmitters. And again, remember the functions of the basal ganglia. So we look for antibodies that are directed against dopamine D1, D2, lysoganglioside. I'll talk a little bit more about that one, tubulin, and then the ability of these antibodies to stimulate what we call calmodulin CaMKII activity. Here are a couple of case reports. We have hundreds of these now, and some of these are being worked into publications. This is a 24-year-old young man who presented with OCD and tics, had a decreased appetite. He lost 30 pounds. Again, either a fear of food contamination or a fear of choking, inability to concentrate, and sensory abnormalities, behavioral regression, separation anxiety. This is also the reason we run all 5 of these, is because in his case, the CaMKII was positive, but the others were not. And we do see this in the case where there is an active infection. This patient was treated with IVIG and plasmapheresis, both immunomodulatory treatments, and resulted in complete symptom reduction. All his antibodies went back to normal. This is a 9-year-old girl who had OCD, verbal tics, and this autism-like stimming behavior, inability to concentrate, sensor and motor abnormalities, emotional ability, behavioral aggression. Urinary and sleep problems are also not uncommon because there's an effect on certain parts of the brain that control some of that. Dysgraphia, aggressiveness, relapsing, remitting in nature. We actually have a case study published on this young girl who was diagnosed with Lyme and also with strep, and then also completely recovered. And actually, I'm sorry, that was another patient. This was another 9-year-old girl. This one was treated with azithromycin with rapid improvement of symptoms. And as you can see, there were 2 antibodies positive with a baseline or a borderline of 1, and they all went back to normal. The other case study I'm referring to, I don't have in this slide. Very similar types of symptoms, very similar type of onset, but was more difficult to diagnose because had multiple infections, and then finally was identified with a Cunningham Panel, and then treatment was directed towards the immune system. We do see some amazing recoveries when patients are properly diagnosed and treated. This is a story about Grace. We have her story on our website. Her mother sent us a video. This is actually an unfortunate situation where she was actually wanting to kill herself. She was diagnosed at 8 years old with a mental disorder. The parents were searching for answers and emptied their 401k twice. We tested her. She was positive. The physicians changed her treatment. Her mother recently sent us a picture of her completely well, back to normal life, and on the cheer team. And we have many, many, many good reports of this. And you who are at the front line taking care of these patients, these are the things that we really love to hear. So more specifically on the panel, I mentioned that the dopamine D1 and the D2 receptor are targets of the autoantibodies. They do interfere with the normal functions of the dopamine D1 and D2 receptor. And when a patient has antibodies associated with dopamine D1, we tend to see these psychiatric symptoms: mood, instability, anxiety, irritability, aggression, and in some cases, psychosis. There are other types of symptoms associated with that, and I won't go through listing them all here. The dopamine D2 tends to be more associated with different type of movement symptoms based on the function of the dopamine D2 receptor and what it innervates. Correlates with choreiform movements and other types of hyperactivity. We also see there is some association with sleep disturbances and other symptoms. Now, antibodies that are directed against the tubulin. Tubulin is an intracellular protein that is believed to control a lot of communication with inside the cell. It's heavily concentrated in the nerve cells. There's studies that show if you mutate the tubulin, that you have patient diagnosis in these cases with, in this case, microcephaly, basal ganglia deficits, dystonia, autism, etc., just showing that there is a connection between tubulin function and some of these mental or neurologic conditions. So when we find antibodies in a patient directed against tubulin, it's typically associated with OCD and cognitive interference. And mostly what we'll hear is the brain fog. Patients will experience difficult focusing and concentrating and symptoms and obsessions and compulsions. Other types of symptoms that are listed here have been associated with a positive tubulin autoantibody. And this is one of the other reasons why we run all 5 of these. Now, Lysoganglioside G1, it is a ganglioside that is involved in the myelin sheath around the nerve cells. You can think of this in the case of like MS, where there's this targeting and deterioration of the nerve or the myelin sheath around the nerve. We do find that when they're directed against the lysoganglioside GM1, there are associations with tics. They also correlate in some cases with joint and connective tissue pain. You can see other types of symptoms, sleep disturbances, OCD, etc. And then the last target, which is really a cell stimulatory assay. I won't go into detail, but we do take human brain cells, not the patient's brain cells. We grow them in culture. We add the antibodies on top of it, pulse chase it with P32, and we look at the ability of these antibodies to stimulate this enzyme called calmodulin CaMKII 2. Why do we do that? Because this particular enzyme, this enzyme is responsible for the upregulation of three neurotransmitters, dopamine, epinephrine, and norepinephrine. So typically what we see when there's an antibody stimulation of the CAM, we see this adrenergic system activation, fight or flight behavior, separation anxiety, sensory. We see the mydriasis, the dilated pupils. And it also has an interesting association that when it is positive, we do find that a patient typically has an undiagnosed infection or a recurrent or a new infection that hasn't been addressed. For some reason, there's an association with these presence of these particular infections that have not been addressed yet, and the stimulation of this CaMKII, which we are studying as to what the biological connection is. But we do find that that's clinical association, and that does help direct what to look for and what to potentially treat. So the other important part is this as calcium calmodulin CaMKII 2 is involved in many other different receptors in the brain. You saw the NMDAR in Brain on Fire, others like this voltage-gated calcium channel receptor, several others. And so this complex interaction is an indicator that this is an important enzyme that if you stimulate it unnecessarily with an antibody, then you can cause other types of neurologic issues that go on. So when you place an order and once you get your results, I'm just going to share with you the report format and then tell you about the helps that we have available to help you. The first page is obviously going to have the results. The green is going to be the baseline. The red is going to be those that are elevated. And then borderline tends to be some things that we do like to keep an eye on. We also find that not necessarily does the severity correlate with the degree of elevation. And part of that has to do with the potential that these antibodies can be tighter binding, but we look for anything that's out of baseline. You'll see some explanation of that in page 2. You will also then see symptom correlation in page 3 that I described there in those slides. Accreditation in the lab in page 4. A little bit of the background that I'm described on the biology of the targets, and then literature references should you be interested. We do include in there the entire publication that we produced, or the study that I'm going to show you in just a second here in the Journal of Neuroimmunology, showing the correlation and the sensitivity and specificity of these targets with patients with infection-triggered autoimmune neuropsychiatric conditions. So that leads to this study here. Here's the reference. You can also find that on our website. Just briefly, we looked for all the patients that had 2 or more of the panels tested, and we found that there were quite a number of them. We looked for those and eliminated those who didn't give us consent to actually follow up, those that were in studies already, and those that actually we didn't get information from. That gave us 58 patients. We divided them up into those who improved or resolved after their treatment, or did not improve or actually got worse after any kind of treatment. Now, this was not a treatment study, but it was an examination of how does these antibodies correlate with symptom improvement or worsening. And that went into the analysis. What we found, which tends to be consistent, regardless of what group they fell into, they all had multiple infections. As you can see here, Lyme, ehrlichiosis, parvo, EBV. I mentioned these other types of opportunistic infections. You see Babesia, Bartonella, Lyme. All others had strep infections, Mycoplasma, Coxsackie virus, parainfluenza. And so infections really are part of this because they're infection-triggered autoimmune neuropsychiatric disorders. So when we looked at the patients who improved and resolved, but they were prior to any treatment, this was their Cunningham panel results. So D1, D2, Tubulin, Lysoganglioside, calmodulin, CaMKII. All of them had one or more targets positive, which we kind of would expect. In those patients who were treated by some means, and we'll talk briefly about that, after that, those that improved, you can see a dramatic reduction in the number of positive tests and the frequency of positives. In this case, you can see from the number of positive tests to that. So some have completely resolved, some have improved dramatically, but all of them at least improved. Conversely, in patients who had worsened or did not improve, this was their pre-treatment test results. So again, let me get that. Not all of them, unfortunately, had a positive panel. So this is what we find is that majority of them did, but that in some cases, the antibodies take a little bit of time to develop. What we did see that after treatment that wasn't effective, all of them except for one had developed by then antibodies, and many of them had increased the number and the frequency of the positive count. So you can see that there's a very close correlation between the presence and absence of these antibodies and their status as far as symptoms and behaviors. What that correlated with was an 86% accuracy. We are also doing more research work to look at weighting these differently. By looking at weighting differently, we are seeing that we can bump the accuracy up to 90%. And then we've looked at studies, and these are available in various other conditions. Other clinicians have published studies, like in schizophrenia, in which they were diagnosed with schizophrenia, but actually was an immune-mediated component. The positive test showed them that they needed to respond or work or treat the immune dysfunction. Lyme, PANDAS, other types of studies, and those are freely available on our website, or reach out to us and we'll send you those. The goal, though, in precision medicine is that we can diagnose patients with neuropsychiatric and behavioral disorders, separate those into those who are genetic or non-immunological or traditional psychiatric and respond to psychiatric medications, and those that are infection-triggered autoimmune that would be responsive to other types of treatment related to what I'll briefly share about here in a second. We are also working with artificial intelligence to try to predict the treatment ahead of time based upon the data and information from the 15,000 patients we have in our clinical database. That's hopefully will come here in the not too distant future. So what does the ordering and testing process look like? You've probably gone through that. If you visit with your patient and take a history and decide whether or not that this patient is a candidate for testing, that order is placed through our portal. We are working also on other ways of making that easier. There is a $995 total cost for the panel, and we require a $495 deposit, which the patient will then pay. Through there, we do bill for insurance and refund anything that the insurance does pay for. We are a very small company, and so one of the things is for us to be able to continue to provide these testing is to be able to pay for these and function. The FedEx will take that and deliver that overnight. You will either be able to, if you might want to stock kits, we'll send kits to you, or it'll go directly to the patient based upon the information that was placed in the portal. We will run these as soon as they come in against the 5 brain targets. They generally will take us anywhere from 2 to 3 weeks because these are highly complex manual, not automated testing. These data will be placed into the portal. It will generate a report, and then you will be notified, and we will bill the patient's insurance as a courtesy. We also have, as I'll share in a little bit, support for different types of help with understanding the report, discussing some of the things that may be questions. So I'll share with that in just a second. Now let's move to the therapeutic modalities, and I'll wrap this up. these are the modalities that have shown to be effective in treating autoimmune encephalopathies secondary to infection. They fall into, and I'm using the PANDAS guidelines, is first rule out other causes. They say in order to get a correct diagnosis, but identify and treat all the infections. As you recall, many of these patients had multiple infections. Often they're subclinical. Since they're infection-triggered, immune-mediated, if you don't eradicate the totality of the infections, or at least have that addressed, sorry about that, what happens is they're still stimulating these immune cells. The other is provide symptomatic relief as necessary, and then treat the inflammatory pathway. Often what's causing some of this is in some cases, about 30% of these patients respond to anti-inflammatories like as simple as NSAIDs as kind of sort of a test. Many of these patients will respond also to steroids, and steroid burst is also one of the things that will be used and has been used. The other is to treat the immune dysregulation if this is not completely resolved. You recall the one patient who responded very rapidly to just azithromycin. In the cases of where these patients have an early diagnosis, the immune system has not been, or I should say the memory B cells probably aren't strong enough, and so therefore the immune response is not as strong. In cases where many years have transpired, often they will need to have some type of immune system treatment because the immune system is very heavily or very strongly activated in these patients. So these effective treatments fall into these therapeutic categories, and I won't go into detail. There's some studies here and some guidelines that I'll share with you. Antimicrobials, obviously, if it's a virus or if it's a bacteria or a certain type of bacteria or fungus, you want to treat those directly. As I mentioned, anti-inflammatories help, and they also let you know that this is an immunomodulatory type of a function. Plasmapheresis has worked in many patients. Immune modulating medications such as intravenous immunoglobulin, and even in severe cases, certain clinicians have used rituximab. And rituximab, if you're familiar with the mechanism, actually removes the B cells in the patient and repopulates, that let the patient repopulate them. So you're effectively removing those autoimmune B cells that are producing these self-reactive antibodies. Obviously, symptomatic treatment is important. So you can see these will generally fall into these categories: anti-infectives, anti-inflammatory, immune modulators, and then, of course, temporary symptomatic treatments. There is some very good guidelines for PANDAS and PANS, but these can be utilized or looked at as a model for other infection-triggered autoimmune neuropsychiatric conditions. We have these publications on our website. They're also there, and the PANDAS PPN, or the PANDAS Physician Network, is another good resource. But remembering PANDAS and PANS can be thought of as medical models. So this will help in your clinical practice by looking and observing at this, even if maybe your patient maybe not be a quote unquote PANDAS or PANS patient. So to wrap this up, we believe that this is just the tip of the iceberg for these infection-triggered autoimmune disorders. Long COVID, Tourette's, epilepsy, schizophrenia, bipolar. And we know that the brain is the last frontier in medicine. And this is important because there are so many people who suffer from various types of disorders here that making strides to be able to test and identify and treat them sooner will make a big impact on medicine. So in summary, I borrowed this TAC law from Dr. Sidney Baker. And the first TAC law is if you're sitting on a TAC, the treatment is not 2 Advil every 3 to 4 hours. The treatment for TAC sitting is TAC removal. And the corollary meaning you search for the root and treat the cause rather than treating the symptoms. And a second TAC law is if you're sitting on 2 TACs, removing 1 TAC does not eliminate 50% of the symptoms. meaning if you don't deal with the infections, but you treat the immune system, the patient potentially can improve, but they may not stay that way because there's still a stimulating component to the immune system that hasn't been addressed. So removing one tack doesn't eliminate 50% of the symptoms. Complex conditions are complex, and to be effective, you need to address all the underlying issues to get a complete resolution. So we provide free consultative services to healthcare providers. For clinicians, you can contact Amy Cross, who was our moderator tonight. She's been helping you for 9 years, working with thousands and thousands of patients and physicians. Any other questions for logistics or anything, you can be directed to our office. We also provide in-service education on symptom association and biological targets in the autoimmune encephalopathy, basal ganglia encephalitis, or what we call the Cunningham Panel. We do have a lot of free resources and publications on our website, and that's at www.molecularlabs.com. And then we also have some hard copy educational brochures for your patients. Our goal is to help you. Because the reason we started is our mission is to bring hope and healing to those suffering from these autoimmune neuropsychiatric disorders. So I thank you for staying here and listening to this in the evening. I also want to thank you for being the compassionate, caring clinicians you are, for taking care of your patients. But we hear some amazing stories of patients getting well, and we're here to help you. If you have any questions, don't hesitate to reach out. Within the few remaining minutes, I guess we'll address any other questions that you might have. So I'll end there and stop my slides. Stop sharing.
Thank you, Dr. Shimasaki. No matter how many times I hear you speak, I always learn something new. So thank you for that presentation. We do have a couple of questions in our remaining few minutes. One attendee is asking you to talk about the utility of testing for adult patients and how long do antibodies persist after an infection?
Right. So those are really good questions, because that does impact really how you treat. We do adult testing. In fact, over 30% of our tests, and now close to 50% of them, are coming from adults, patients 21 years or older. The normal controls that we have listed in the clinical studies we've done are based on children. What we do find, though, in clinical practice is that these are very good surrogates for that. But one of the other studies that will be working on is large volumes of quote unquote normal adults to see if there's any variation in that. However, we do find that these are representative, and that the patients who have elevated antibodies in here who are adults do also have these symptoms and tend to respond to the same types of treatments. So more studies to come, but it has been helpful in these cases for adults. So how long do the antibodies persist post-infection? Probably this is something that has been talked about a lot since COVID and vaccinations and that. As long as there is a stimulus, meaning as long as there is an infection that remains, the immune system is going to continue to try to deal with it. So if there's infections that are persistent in many cases, such as Lyme, some of these other, such as Bartonella and Babesia, that can and have these life cycles, these continue to go on for long periods of time. We're talking years, and many of these patients you see have had these chronic infections. In some cases, they don't even know that until they're actually being tested for it. So the takeaway is that as long as these infections are present, these antibodies will be also present, because that's how the immune system will function. And that's the reason for addressing both the infection and the immune system. Now, if the infection is gone, there are memory B cells, and this is part of the immune system response for a second infection that occurs, but the amount of antibodies that are produced are less. So part of this is what's the degree of symptoms and how long has this been? And then this is why we measure these antibodies even before and after treatment to see if they're still present. So it can vary, but as long as the infection is present, these antibodies will be present.
In our remaining 1 minute, there's another question that I'm actually asked quite frequently, and that is, do antibiotics or psychotropic medicines interfere with the Cunningham panel results?
Yeah, that's a great question. Antibiotics and psychotropic drugs, to our knowledge, do not interfere, and we have not seen that, principally because the biology of the interactions is not related to do anything in those cases to the immune system. We do see interferences with immune modulatory treatments. So anything that will modulate the immune system has the potential to, I won't say interfere, but could alter the results. Because remembering, this is a biological testing assays. We're looking for a point in time in which the level of these antibodies are present at certain levels. And therefore, if they're treated with some immune modulatory treatment, we could get a different result. So we do usually request and talk to the clinicians that we still can test, and often it's an important piece of information as long as the patients have symptoms. And if they are going to go on immune modulatory treatment, we do want them to either collect it before that or after a period of if they're either cleared or it's no longer in the blood system.
Okay, thank you, Craig. We are at our time limit, so please, everyone, accept our thanks for participating in our webinar this evening. Please feel free to contact us to help you with your patients or with the panel. And again, just as a reminder, there will be a link to this recording sent to your email inbox within a couple of days. So again, thank you very much. And thank you, Dr. Shimasaki.
Thank you, Amy, and thank you, everybody who joined. Bye now.
Bye-bye.